Professor Nalini. She is a very well-known neurologist and she works at National Institute for Mental Health and Neurosciences, which is an institute for national importance situated in Bangalore. She actually leads the multidisciplinary neuromuscular clinic, which was established in NIMANS in 1991. So far, more than 10,000 patients have been diagnosed and being provided care in the neuromuscular clinic established at NIMANS. Professor Nalini has been in the forefront of clinical and genetic as well as different and hardcore basic research in terms of neuromuscular, and she has more than 145 national and international publications. She is a very well-known name in the myology group, and she also has been the recipient of prestigious C.V. Raman Award, and she is a board member of Asia Oceanic, and she is also an invited member of Asia Oceanic Inherited Neuropathy Consortium. Today, Professor Nalini is going to talk to us about congenital muscular dystrophy and share her experience on this enigmatic neurological neuromuscular disorder. So before we go to Professor Nalini, my request to you is, number one, please mute yourself and only let the speaker speak. And if you have any questions, you can either raise, you please put your question in the chat box. You can also communicate to Swami, or you can raise your hand and we'll pick it up. And please keep your till the end of the talk. Thank you very much. Ma'am, please, I welcome you again, and we look forward to listening to you.
Thank you. Thank you, Dr. Sudhakar. Thank you, the Rare Disorders India team, for this fantastic work that you all have been doing. I'm very pleased that all of us know that neuromuscular disorders is a group that is totally neglected by neurologists, not only in India, elsewhere in the world also, but particularly in India, there is a nihilistic attitude towards the neuromuscular disorders because they're rare and majority of them do not have any specific treatment. And I'm happy that I've been given an opportunity to share my experience over the last few decades on congenital muscular dystrophy, and it's definitely a very rare combination of disorders under the neuromuscular group. Yeah, I'm sorry. So let me first thank my collaborators, my faculty, junior faculty like Dr. Seena Saraswati, Dr. Gautam is our human geneticist, our clinical geneticist, and my PhD scholars, Dr. Kiran Pritish, who have been a very strong team behind the successful neuromuscular disorders that we continue. And I thank Dr. Nalini Atchayaram and Dr. Sudipta Roy from Kolkata and Singapore, that NIBMG, who have particularly taken part in the genetic diagnosis and doing whole exome sequencing and several of our patients with congenital dystrophy. So this is our neuromuscular clinic, which commenced in 1991 under the tutorship of Professor M. Gauri Devi, which is one of the most successful clinics that is running in this institute. So we have various specialized people contributing to the success of this clinic, the psychiatrist social workers, the rehabilitation specialist, Dr. Anupam Prakashi ma'am, the occupational therapists, the Ayurvedic physicians who help us a lot, and particularly our patients are fond of taking these drugs, and they do have some definitive improvement, at least subjectively. So congenital muscular dystrophies was first described by Batten in 1903, wherein 3 children who had proximal muscle weakness from birth and whose biopsy showed chronic myopathic changes. 5 years later, Howard coined the term congenital muscular dystrophy, and almost 20 years later, Ulrich described the combination of joint hyperlaxity and proximal contractures, which is a very specific finding in Ulrich congenital muscular dystrophy. And again, after 30 years, Fukuyama described a common congenital muscular dystrophy in Japan, and mentioned that they also had muscular dystrophy with brain pathology. So this is the most interesting component of this group of disorders, that the brain and the eye is also involved with primary muscle involvement. So the genes that encode for several of these proteins of the muscle protein complex get affected, which gives rise to several neuromuscular disorders, and particularly with the CMD, you have the laminin alpha 2 or the myrosin protein, which is an extracellular matrix protein that links with the dystrophin, which is in the sarcoplasm, through the alpha-dystroglycan complex. You have the collagen 6, which is again extracellular matrix protein, which maintains the regularity of the muscle function. The alpha-dystroglycan group is the most important and very interesting group among these disorders, and this is also found in the nerve, the heart, and the brain, apart from the muscle. And it binds the myrosin or the laminin alpha 2 from the extracellular matrix and bridges it with the cytoskeleton molecules, which includes the dystrophin and the actin, through the alpha-dystroglycan complex. So CMD affects both males and females in equal numbers because it is an autosomal recessive disorder in majority of the cases. There are no incidence studies from India, but however, in the Italian population, it is reported to occur 1 in 125,000 population, and this is very rare. Nevertheless, in certain places like Western Sweden, it occurs 1 in 16,000 births, and this is very common. And some forms of CMD occur with greater frequency in certain ethnicity, like the Fukuyama CMD, which is said to be almost exclusively seen in Japan, but nevertheless now it is confirmed in many other nations, including our place. The muscle eye brain disease occurs with greater frequency in Finland. So what are the classical features? These genetically mediated disorders usually occur at birth or early infancy. And as mentioned, they're predominantly autosomal recessive. Classically, they're characterized by hypotonia, similar to a rag doll, and floppy baby at birth. There's a progressive muscle weakness and wasting. Prominent contractures are a classical feature along with spinal rigidity. Uniformly, they have delayed motor milestones, but mental milestones is affected in a group of them. Feeding and breathing difficulties occur in certain types. Structural brain defects, intellectual disability, particularly in the dystroglycan group of disorders. And some of the disorders have elevated serum creatine kinase levels, similar to dystrophic pattern. The severity, symptoms, and progression also vary greatly. So this is typical of a floppy child, wherein you see a frog-like position, internal rotations of the arms, and this is a scarf sign. On suspension, there is inability of the baby to lift the head up, and also in the prone position. A little older child with frog-like position and head lag. So these are classical signs of a floppy child, which is also stimulates a ragdoll appearance. The congenital muscular dystrophies are categorized into 3 main groups based on the defects in structural protein, like the laminin alpha 2, which gives rise to the myrosin deficient CMD, and collagen 6 related alpha 1, 2, and 3 proteins, which gives rise to the Ullrich congenital muscular dystrophy and Bethlehem myopathy. And you have the interesting group of dystroglycan groups, which presents as Walker-Warburg syndrome or muscle eye brain disease, Fukuyama congenital muscular dystrophy. So here it's very important that one disease can manifest with multiple or different gene mutations, and it could be vice versa. And defects of the proteins of the endoplasmic reticulum, as you can see here, which I have highlighted, which gives rise to a rigid spine syndrome called due to selenoprotein 1 deficiency. And protein function is yet to be known in this particular group. And you have the defects of the nuclear envelope proteins like the Lamin AC and that is the Emery-Dreyfus muscular dystrophy. So this is a very convenient classification proposed by Bonneman et al. In 2016. And he's a pioneer in several of these disorders. So you can have the laminin alpha 2 related CMD and the dystroglycan groups, which is the congenital disorders of glycosylation. So you have the Fukuyama, which is commonly seen in Japan, the muscle eye brain disease due to the defects in the genes of POM, GNT1, FKRP, ISPD, and others, Fukutin. So as I said, the same gene could cause different phenotypes, and the same phenotype could be caused by different genes. So that's very peculiar in this group of disorders, and this occurs in many other degenerative diseases. So as we go on, I will be describing on each of these groups that we have seen. So our experience at NIMHANS almost over the last 12 years since we started doing the genetic studies is about 79 cases, and most of them are almost all were confirmed by whole exome sequencing or clinical exome. So the commonest that we have encountered is the collagen 6 related congenital muscular dystrophy, followed by the LAMA2 or the myrosin deficient. And in the alpha DG group also we have predominantly the FKRP, the POMT1, 2, and the B3 Galen T1. And we also have the Lamin AC group, and very rare ones we have, and majority of them had pathogenic or likely pathogenic mutations. A handful of cases have been described worldwide on the megaconial congenital muscular dystrophy, particularly the mitochondrial gene mutation, which is under the CMD group. We have about 3 classical cases. So moving on to the individual groups. So the group of defective structural proteins, that is the collagen 6, is the commonest that we have seen, and particularly in southern India, as there is consanguinities in about 33% of the marriages. So autosomal recessive disorders are commonly encountered at our outpatient clinics. And UCMD is a severe form, whereas Bethlehem myopathy is a milder form of the collagen 6 type disorder. So they generally have hypotonia, muscle weakness. What's classical is that this is a disorder which has a combination of contractures in the proximal joints and hyperlaxity of the distal joints. So this is very, very classical and almost a clincher to the diagnosis. And intelligence is normal in this group. Motor abilities could be very severe to mild. Because of the collagenopathy, they have velvety palms and soles, and a reticular pattern of the creases. The major creases of the proximal, middle, and the distal are generally absent, and there's hyperkeratosis of hair follicles and a rigid spine. So classical features, as you can see, contractures of the hip joint, knee joint, at the elbow and shoulder, whereas the distal joints are hyperextensible at the foot, and you can see literally you can do a reverse flexion of the fingers. They also have prominent calcaneum, and what's interesting is that they have the soft velvety absence of the major creases and a reticular pattern which is not described, and I thought that was very peculiar in almost all of our patients with UCMD. So these are 3 different patients, 3 years, 5 years, and 4-year-old. We found that this particular phenotype of an incurved little finger, which is seen in, gives us a very important bedside clinical clue that this patient may be having Ullrich congenital muscular dystrophy. As you can see, the reticular pattern also, and one of these patients has got a confirmed pathogenic mutation in the COL6A2 gene, and it was a homozygous mutation. Yes, earlier, maybe 5 to 6 years ago, muscle biopsy was a mainstay for us to show immune deficiency of the various proteins with antibody positive or negative. And I just thought for completion that recently we have our first line of investigation after doing a CK or a TMS is genetic studies by clinical exome, and I think in majority of the patients we get a positive result. So here you can see the classical dystrophic features of variation in fiber size and increased endomysial fibrosis in this group, and this is normal with normal expression of the COL6 alpha 1. There's a partial deficiency here. You can see the sarcolemmal specific deficiency, and here there is total absence. So in Ullrich congenital muscular dystrophy. So the next group is interesting, and it's called as the Bethlehem myopathy. It's predominantly autosomal dominant, and it could be recessive also. The 3 genes encoding for type 6 collagen, that is alpha 1, 2, and 3, they usually have an onset before birth with decreased fetal movements, and at birth they have low muscle tone and they can have delayed motor milestones. So as I said, this is common for all CMDs. And in adulthood also there could be weakness They could be having contractures at the Achilles tendon, and finger contractures are very classical. In addition, they can have skin manifestations with follicular hyperkeratosis, soft velvety palms like Ulrich, but it's not as prominent as in that. And because of the collagen defect, they have poor wound healing and shallow scars. They have easy bruisability also at times. So the clincher in this group of disorders is the presence of keloids. This child underwent multiple tendon lengthening surgery for contractures and developed keloids. So you can see the finger contractures.
University of Health Sciences USA to chair this session.
And here there are finger contractures. And this was a 6-year-old boy with prominent weakness, contractures, and keloids. So when you find keloids in a child with a myopathic feature with finger contraction, your diagnosis would be at the bedside Bethlehem myopathy. So this child showed a COL6A2 mutation, which is homozygous for the Bethlehem gene. Another child with prominent contracture, she had very mild, small keloids following falls and injuries and distal hyperlaxity of the joint. These two brothers, very interestingly, keloids appeared spontaneously, and you can see the extensive keloids that this boy has, the younger brother, whereas the older brother does not have keloids. So there is a phenotypic intrafamilial variability. Interestingly, both the brothers had very early graying of the hair, which is not described in the Bethlehem myopathy series. So this could be like skin manifestations or keratin, maybe the hair is also involved, but that needs further studies. So these two brothers, one of them showed the mutation in the COL6A1 gene. And in this group of disorders, CK is generally normal to minimally elevated and not like dystrophic pattern. So this father and daughter had brought to us, and this gentleman was diagnosed to have poliomyelitis because he was crouching and walking, being mobile, and he underwent acupuncture and he developed very prominent keloids following acupuncture. His daughter has nuchal rigidity. She is just 11 years old, but she had a more severe disability, just as we see in anticipation in autosomal dominant disorders. This we reported, you can see the father and the son with extensive keloids and follicular hyperkeratosis, which was seen in the son and not in the father. So the next group is the defective structure proteins. Similar to the collagen, it's an extracellular matrix protein, which is the myrosin or the laminin alpha 2. So similar to the other groups, infants are affected and they have a combination of hypotonia, joint contractures, which are present at birth. And in addition to skeletal muscle, the Schwann cells, cardiac muscle, and placental villi can be affected. And precisely that's the reason these children can also have a peripheral neuropathy in addition to muscle involvement. And they can have failure to thrive with respiratory and feeding difficulties. And seizures is seen in 20 to 30% of patients. And we have had referred cases who first went to the epileptologist or pediatric neurologist with seizures and later on developed features of muscle involvement. So usually they're very severely affected and they hardly sit or stand in their lifetime. So classically, these are brother and sister. You can see the contractures at the elbow. And this child had megalencephaly. So big head with white matter changes. So one tends to make a diagnosis of a leukodystrophy. But what's different is that in congenital muscular dystrophy, the U fibers are involved and white matter changes are seen similar to the leukodystrophy, but there it is a demyelination. Here it is just edema. And CK is grossly elevated in these patients. So a megalencephaly with severe muscle weakness, hypotonia, as you can see, and white matter changes. And interestingly, though they have white matter changes, there is no mental subnormality in these children, and they're very bright children. So this child had a LAMA2 mutation with compound heterozygous state and pathogenic mutations. So again, as I said, we've given up doing muscle biopsies because genetic is non-invasive, just a blood sample, and it's affordable and available in several centers in the country, and we can make use of the facility rather than subjecting the small children to invasive, painful procedures. Yes, we did it when a time when genetics was not available. So you can see the dystrophic features are normal expression of myrosin, partial deficiency, and a total deficiency of myrosin. Yes, sometimes when the phenotype is very extraordinary, we tend to do a muscle biopsy, and many times it is after a genetic report, nowadays sometimes we choose to do muscle biopsy. The interesting group of disorders, as I said, among the congenital muscular dystrophies is the dystroglycan group. So I do remember that Sudhindra requested me to talk on congenital disorders of glycosylation, but that's not my expertise because most of them have mental retardation, epilepsy, and they would go to the child psychiatrist rather than coming to the neurologist. But when they have muscle involvement, it becomes very important. So dystroglycan, as we know, links the extracellular matrix along to this with the cytoskeleton, and it is crucial for the stability of the plasma membrane. It has two subunits, alpha and beta dystroglycan. They bind to molecules like laminin and agrin, and absence causes damage to muscle fibers, and code for specific or putative glycosyl transferases which are involved in the pathway of alpha dystroglycanopathies. So what's important here? Dystroglycanopathies, the concept of one gene, one disorder does not follow here. And as I said, one gene causes multiple phenotypes, and one phenotype could be caused by different genetic defects. So potentially it is associated with more than one disorder. Mild phenotypes would be there to severe ones. And particularly cases of MDC1C are associated with structural brain abnormalities, impaired intelligence, and seizures. So the alpha dystroglycan related dystrophies, this is the Walker-Warburg syndrome, the muscle eye brain disease, and the Fukuyama CMD. So you almost have 7 different genes which can cause a Walker-Warburg syndrome, POMT1, 2, GNT1, large, Fukutin, etc. So the protein O mannocell transferase deficiencies, and they have very severe congenital weakness and brain anomalies, particularly lysencephaly, which is called as a smooth brain, or you can have a bumpy brain that is called as the cobblestone defects. And in muscle eye brain disease, again, you have very severe manifestations with epilepsy, and again lysencephaly of type 2 with pachygyria. And the Fukuyama congenital, again with severe mental retardation and with brain changes. So the brain changes are almost similar in all of these groups with dystroglycanopathies. So FCMD, apart from the muscle, as I said, weakness, wasting, contractures, the brain and eyes are involved. And typically in Fukuyama, you can have hypertrophy of muscles, particularly the calf muscles could be hypertrophied, whereas in Lama 2 and Woolrich, there's no hypertrophy, there is only wasting, or there may not be any wasting. They can have weak cry or poor feeding at birth. In addition, ptosis, open mouth, and contractures can be there. So as described, the brain can show cobblestone lysencephaly, and these could be a bumpy, irregular appearance on the surface. So these patients usually have delayed milestones with severe intellectual disability. Their social skills are less severely impaired, but intellectual disability is prominent. And most of them are never able to stand or walk. And although some can sit without support and slide. So more than half or 50% of these children have seizures. So again, to reiterate, we have had children who were continuously under follow-up either with a child psychiatrist because of mental retardation or ADHD or autistic features. And when they developed seizures, they came to us. And very recently, we had a patient of 16 years with LAMA2 mutation who had only a single seizure, and the CK was in 4,000. And when we did the MRI, it was classical of congenital muscular dystrophy. And all that he manifested was with a single seizure. So Fukutin-related protein deficiency, they can mimic a Duchenne phenotype, like with calf hypertrophy, mental subnormality, macroglossia, and some scapulovinging. But some of them can have very severe mental retardation. So the classical FCMD is usually very severe, they hardly walk. But can also have the milder forms. So this boy had a raised CK, a DMD-like phenotype, a 3-year-old child, but brain showed evidence of white matter changes. And his genetic test showed that he had a POMT1 gene mutation, which was again homozygous. So this pattern of identification says that doing MRI of the brain becomes very important so that we are able to phenotype the patient. So if you think of Duchenne muscular dystrophy, you will start doing a MLPA, and MLPA is not going to show us any defect, but instead we have to do a mutation analysis or a next generation sequencing in these patients. So classically in Fukuyama or the POMT group, it could be POMT 1, 2 or POMT GNT1, you can have brain changes. So you have extensive white matter changes or dysplasia of the white matter and the brainstem. You can have micropolygyria. You can have the cobblestone appearance, as I said, bumpy surface of the brain. Whereas in lysencephaly type 1, you will have a smooth brain. And cerebelluses, as you can see here, you have multiple cerebelluses, and occipital agyria can be the flattened. You can see that the brainstem is completely atrophic, the cerebellum is atrophic, the pons and the brainstem, the medulla is totally atrophic. So these are the several changes that can be seen with the alpha-dystroglycan group, particularly with Fukuyama and the other group of disorders. So when it comes to muscle eye brain disease, you have a spectrum, like particularly of the POMT GNT1, which can be affected, which is located on the long arm of the chromosome 1. So here we find that infants have profound hypotonia. They can have severe muscle weakness at birth. They do not attain any motor milestones, and majority of them have failure to thrive. There can be developmental delays and ocular abnormalities. There can be milder forms as well. They have delay in attaining developmental milestones. Eventually, they may be able to walk independently, but never have the functions are always impaired. So over the time, they do develop severe spasticity of the muscles. So I have put these images everywhere so that one can see this is the highlighted one, and the Golgi apparatus has particularly these proteins which are expressed, that is FKRP, fukutin, POMT GNT1 and the large gene, and very rare disorders. And you have the endoplasmic reticulum also, which expresses POMT1 and POMT2. So what's in addition to the muscle weakness that these patients have? So the disease spectrum consists of megalencephaly. They could have a large head with a prominent forehead. They can have micrognathia, mid-face hypoplasia, a short nose, abnormally small groove between the upper lip and the tip of the nose, that is the philtrum, infantile glaucoma. As I said, the brain and the eye gets affected with them because dystroglycan is expressed in muscle, brain and eyes. They can have severe mental retardation. Epilepsy is very common. And as you can see, this brain, actually this is a child, and I just put this MRI here, and this is the MRI findings of the child as I will show the clinical features. So pachygyria or lysencephaly, it could be type 1 or type 2. Either it could be smooth brain with agyria, or you can have a figure of 8 appearance classically. So here it is particularly the smooth brain with hardly any gyra, which is, and we know that this is a neuronal migration disorder which usually happens between the 8 to 12 weeks of gestation when the migration is abnormal, and they can also have band heterotopia in the subcortical regions, and you can see the thick cortex and white matter abnormalities in this, and there is a ventricular megaly. But brainstem is literally totally atrophic, and there is hypoplasia of the cerebellum. A very small cerebellum is seen. So these features give us a clue that these patients could have a congenital muscular dystrophy. So eye signs, they can have cataract, nystagmus, retinal hypoplasia, and congenital myopia. So the mutations in the ISPD gene, which is located in the chromosome 7, can give rise to alpha-dystroglycan disorder. So here we have a child with Walker-Walker syndrome features, or it could be muscle eye brain, secondary to POMT T1 mutation. And this child, you can see, had a big head, had a small encephalocele over here, opisthotonus, severe spasticity, what we call as buphtalmos. They usually have a very prominent eyeball which is called as buphtalmos. The child also had megalocornea, which is seen, and multiple defects like hypertelorism, depressed nasal bridge, and the child was completely blind and had not attained any milestones. So in addition, you can see ocular-wise retinal dysplasia. As I showed in the previous one, you can have obstructive hydrocephalus, occipital encephalocele, severe growth failure, and these children generally do not survive beyond their first birthday. So brain anomalies, as I already mentioned, classically you have abnormalities of the gyri, or they can have type 1 and type 2 lysencephaly or the cobblestone lysencephaly. So this is with what we call as the GMPB gene. So generally in our experience, we have seen adults presenting as limb-girdle muscular dystrophy with features of congenital myasthenic syndrome, and our experience is with the homozygous mutation in the GMPPB gene. But the same gene could also cause dysfunction in the newborns or in very young children and can give rise to what is called as a severe congenital muscular dystrophy or the Dystroglycanopathy with brain and eye anomalies. We have no experience on this. There are very few cases reported, and it's a very newly described disease where you can have CMD Dystroglycanopathy, and these children can have severe mental retardation along with microcephaly, cardiac dysfunction, seizures, or cerebellar hypoplasia. And OMM classifications, we know that it is with MDD-GA14, and these children have features with increased muscle tone, microcephaly, cleft palate. They can have very severe feeding difficulties, and sensory neural hearing loss, which is not a feature of other groups of congenital muscular dystrophy, but they can have common features like cerebellar hypoplasia, cerebral ataxia, and retinal dysfunction. So we do not have much experience on this. So yes, this is called as the rigid spine syndrome. We do keep seeing such cases very infrequently. So the SEPN1 gene is located on the short arm of chromosome 1, and it encodes for a protein found in the extensive membrane network that is in the, as I've shown here, in the sarcoplasm, you have the endoplasmic reticulum. So CMD with early rigidity of the spine can manifest in 4 different muscle conditions like the rigid spine syndrome, congenital fiber type disproportion, Desmin-related myopathy, this is a different Desminopathy it is called, or a multimini-core myopathy. And collectively, they are called as SEPN1 related myopathy. So hallmark of this group of disorders is early rigidity of the spine, which usually develops in the first year of life. And there's a progressive scoliosis, which usually occurs from 3 to 12 years of age. Progressive muscle weakness. You can have hypotonia, contractures of the Achilles tendon, lack of head control. Breathing difficulties are progressive, and by teenage years or later, they develop restrictive type of pulmonary deficit. Eventually, they have nocturnal hyperventilation and respiratory failure. So you can see this adult man, though he was symptomatic from early childhood, he came to us almost when he was 25 years of age, and he has a very thin, slender build. His muscles mass is less, but nevertheless there is no focal atrophy or hypertrophy. But what's prominent is the rigid spine and nuchal rigidity, where he cannot bend forwards if you ask them to touch their toes. So this is a clinical bedside sign that we all have to see. So it should involve a complete examination of the patient, and if we don't ask them to bend forwards, we are going to miss out on this rigid spine. So this is another child, like as you can see, it's not as severe, but he's younger, is about 10 to 11 years old. This boy predominantly had only nuchal rigidity. Again, as you see, we used to do biopsies, but they were all non-diagnostic, or sometimes they just show features of multicore, mini-core, or like congenital myopathy features, but genetics is the ultimate. So reiterating that once we do a clinical phenotype of the patient, getting genetics as a first line diagnostic test will be very important for us. So this child had a SEPN1 homozygous mutation, which confirmed the diagnosis of rigid spine syndrome in this patient. So the next group is defective proteins of the nuclear envelope, like as in the, again in the endoplasmic reticulum. So the Lamin AC-related congenital muscular dystrophies. And this gene encodes for two components of the inner nuclear membrane. So this is involved in nuclear stability, the chromatin structure, and this gives rise to severe presentation that occurs during the first 6 months. And as a common manifestation, they have hypotonia, generalized muscle wasting and weakness, but in addition, they can have spinal rigidity. Also, dropped head syndrome could be a feature. So this rigidity is particularly prominent in the neck, arm and feet, and scoliosis and lower limb contractures are common. So again, as I said, we predominantly see adult patients, but this patient had an onset from early childhood, and classically in Emery-Dreifuss muscular dystrophy due to Lamin AC mutation, you have early contractures at the ankles and at the elbow. So this is a particular peculiar stance of the patient with Emery-Dreifuss, where they have mild abduction because of the flexion at the elbow and with toe walking, and they have heel elevated. So he has gross difficulty in rising from the floor, and this gene encodes for the protein Lamin AC and Lamin C. Classically, they have early contractures, but very important in this group that they can have cardiac manifestations. They can have arrhythmogenic cardiomyopathy, they can have dysrhythmia, and this could be lethal at times. So apart from their muscle weakness and slow progression, taking care of the cardiac conduction defects and identifying these early becomes very important for every clinician who takes care of these patients, and they can have an early implantation of a pacemaker, and at times they have to undergo cardiac transplantation. So cardiomyopathy is generally a dysrhythmic or arrhythmogenic type of cardiomyopathy rather than dilated cardiomyopathy. The severity could be vary, but apart from the muscle weakness, the heart is the main cause of death in these patients. And annual checkup, once a diagnosis is made, and identifying a subclinical dysrhythmia is very important. So this patient had a mutation in the Lamin AC gene, and it was a compound heterozygous mutation, and which was likely pathogenic. Handful of cases reported worldwide, hardly 10 to 12 cases. We had the fortune of having 3 confirmed cases of CHKB-related muscle disease, or the choline kinase B gene, which is located on the long arm of the chromosome 22. And this is particularly you have giant mitochondria in the muscle biopsy, which this particular child had it. Unfortunately, I do not have the pathology pictures with me. And this gene encodes the protein choline kinase beta congenital muscular dystrophy with mitochondrial structural abnormalities. So it's called as the CMD mitochondrial disease. Extremely rare, as I already mentioned, and fewer than 20 individuals reported worldwide. They have severe intellectual disability, they have hypotonia, generalized muscle weakness, and later on in the illness they can develop dilated cardiomyopathy. So this child, who was a 4-year-old girl, had severe mental retardation. As you can see, very prominent ichthyosis, and in fact it was very, very itchy, and she was all the time scratching. She had a very short stature. She had autistic features. So some of the features are classical of mitochondrial disorder as well. And she had a homozygous mutation, and it is called as a megaconial type of congenital muscular dystrophy. So as we have no experience with this, although in our group 2 patients had this mutation, but they were variant of unknown significance, so we are not sure whether they were pathogenic. So it is the synaptic nuclear envelope 1 gene, which is located on the long arm of chromosome 6. Extremely rare, only reported in 2 siblings. They usually have adopted thumbs, intellectual disability, cataract, ophthalmoplegia, and cerebellar hypoplasia. So what's going on with the management of these patients? So I do have some more time. So meticulous clinical examination, bedside phenotyping is the most crucial aspect of diagnosing any of these degenerative diseases which are genetically mediated. So I always tell this, that no amount of laboratory testing, including genetic testing, can compensate for an erroneous impression based on an incomplete, hastily performed history and examination. So time and again we see patients, and we have also made that mistake, that we see a case of congenital myopathy, we'll make a diagnosis of mitochondrial myopathy, and the genetic testing for mitochondrial disorders is completely different than what we would do for congenital myopathy. We see patients of SMA, just because a hasty clinical bedside diagnosis was made, it's just say floppy child, you get your clinical exam done. Clinical exam is negative, then they will go for a whole exam sequencing. Whole exam sequencing is negative, they go for whole genome sequencing, and everything is going to be negative. A simple MLPA testing will give us a diagnosis. So identifying and characterizing the phenotype at the bedside, spending time taking history and examination is very important. So you think it's a dystrophy, whereas it is an atrophic disorder. Similarly, with myotonic dystrophy versus LGMD, this is a repeat disorder, and any amount of mutation testing is not going to give us this diagnosis. Similarly, FSHD, which is a contraction disorder or another repeat disorder, versus LGMD. So doing a clinical examination and phenotyping has become all the more important with the current scenario of genetic confirmation. So we have to choose the correct and appropriate gene test for confirming what the child or what the patient has, particularly in neuromuscular disorders, where almost 100% of them are genetically mediated disorders in the inherited group. So again, reiterating, spend time with the patient, examine them thoroughly, and have a phenotype in mind, and then you can direct your genetic testing. Obviously, several years ago, we just did muscle biopsy, and the report will be either dystrophy, atrophy, and immunohistochemistry, which came on later into the picture. So biochemically, we'll do the CK level, the liver enzymes, and a suspicion of mitochondria is there with lactate and ammonia. Uniformly, all of them will get a cardiac evaluation to look for dilated cardiomyopathy or ECG for evidence of rhythm disturbances. Brain MRI, as I already mentioned, to identify the anomalies. Nerve conduction studies to look if they have additional peripheral neuropathy. Yes, muscle biopsy, we have now gone beyond muscle biopsy to genetic testing. Treatment, we know that there is no specific treatment, but regular physiotherapy and occupational therapy is very important, as most of them have contractures. Pulmonary and cardiac problems need to be appropriately taken care of. Tendon release surgeries for contractures could be useful. Epilepsy, you treat appropriately. Cardiomyopathy with particular drugs. And bulbar symptoms if they have. Yes, scoliosis surgery can help them, and particularly this could compromise their respiratory ability. So genetic counseling. So till now what we spoke was, we have patients who are already affected, and how do we diagnose them and how do we manage them? Now what's important, particularly in this group of disorders where there is no specific therapy, there is no cure for these diseases, is prevention. So that future pregnancies in particularly young couples can be prevented. So we need to give them genetic counseling and prenatal testing. So we need to have board certified genetic counselors and medical geneticists, like we have Dr. Gautam with us, who is really very helpful in genetic counseling for all our patients. So the interpretation of the genetic test should be done correctly. Medical and psychological intervention is necessary. The family implications of a child or a family member having the genetic disease is very crucial. Education about the pattern of inheritance, like in recessive disorders and in dominant disorders, is important. Family planning options. What is the type of genetic test that can be done to confirm the diagnosis in these children? And explore emotional and family issues, and recommend resources like particularly the parents associations or parent groups or disease groups, which they can have access to and know about the disease and all others who are also suffering from similar illnesses, because this is such a rare disease group in neuromuscular disorder itself. So prenatal diagnosis is very important wherever it is possible, and if parents are keen, so we can go for invasive prenatal testing by chorionic villus sampling or by amniocentesis. So we can also do pre-implantation genetic diagnosis after in vitro fertilization, but this is very expensive. And pathogenic variants should always be identified before we contemplate prenatal diagnosis. And this should be validated by the initial genetic testing and post-NGS results by Sanger. So prenatal testing for carrier status can be achieved by recessive CMDs, asymptomatic carrier and dominant CMDs with reduced penetrance or variable expressivity, particularly like Col6-related CMDs, you can do prenatal testing. So chorionic villus biopsy for advice, it's generally done between 11 to 13 weeks of pregnancy, and informed consent to perform the genetic test should be done, and this can be done by a genetic counselor or a clinical geneticist. It's usually a daycare procedure. As you can see, fetal loss is only around 1% after the procedure, which is in addition to the background risk of miscarriage at that gestational age. Maternal contamination testing is mandatory, and sex of the fetus is not revealed after this procedure. So we can also go with the amniocentesis, and again a similar procedure, an informed consent is done, and both these procedures are ultrasound guided, and here the fetal loss is less. There it's about 1%, here it's about 0.5%, and after the procedure, and similarly you can have a background risk of miscarriage at that gestational age. Current research, I would first go on to this slide, and this I've taken from Professor Bonneman's lab at NIH USA, where we know that it's a long way beyond for coming to the understanding itself of congenital muscular dystrophies, and particularly the dystroglycan group of disorders. And even now, the molecular processes that lead to muscle loss is under experimentation, and methods to counteract these processes are underway. In laboratory rodents, and studies are ongoing for gene therapy or gene transfer mechanisms. Either there could be a directly supply of the missing protein, or proteins that help compensate for a missing or abnormal protein. There is a theme of blocking the activity of harmful genes in lab models of CMD. And I'm sure that every basic scientist would be extraordinarily interested if something could come out for these rare disorders by clicking on any one of these, which could be successful either in the near future or in the long run. They also have research with understanding early stage of muscle development in normal and abnormal situations. And the knowledge of this could be applied to fixing what goes wrong with muscle development in CMD. And this could lead to stem cell treatment for CMD. And I'm sure that many parents always ask us, can we give stem cell therapy? So they think that's the panacea for all degenerative diseases, but it is not true except for certain conditions, but none in neuromuscular disorders. There is still a need to fully understand the process of glycosylation of proteins, particularly alpha-dystroglycan, which is not sufficiently glycosylated in congenital muscular dystrophies. And understanding and correcting this process is a promising avenue for treatment of these disorders. So some research is going on where agrin can bind to laminin and to alpha-dystroglycan, which might be able to functionally rescue the weakened muscle, particularly in LAMA2 mutations or myosin deficient CMD. And the agrin transgene, which has improved general health, lifespan, and locomotor activity, particularly in the CMD mutant mice. And this study demonstrates possibly the potential for gene therapy with non-homologous proteins that functionally compensate for gene mutation. So let's wrap up the clinical features, and we have had a big cohort of almost 80 cases with genetically confirmed. So once again to say that there are three main categories: defects of structural protein, particularly the myosin deficient, the UCMD and Bethlehem myopathy, the defects of glycosylation with the formed group of proteins, the large gene, and defects of protein of the endoplasmic reticulum like selenoprotein or the rigid spine syndrome, which I've demonstrated, and the emery-Dreifuss muscular dystrophy, particularly with cardiac manifestations. So an approach to congenital muscular dystrophy, if you have an infant or a young child with hypotonia, contractures, proximal muscle weakness, you look first for the axial involvement. If there is a rigid spine, you would think of possibly a Lamin AC-related CMD. And if there is appendicular involvement, particularly of the limb muscles, and with wasting, weakness, contractures, and if the MRI is normal, you think of Col6 CMD. But obviously, Col6 has several manifestations, as I said, proximal contractures and distal hyperlaxity. If there is abnormal brain MRI, you look at the cognition. If it is normal, it will be murosin negative or the laminin alpha 2 mutation related disorder. If it is abnormal, you have cognition, which is abnormal eye involvement and brain involvement. Then you think of muscle eye brain disease, Walker-Warburg disease, or Fukuyama congenital muscular dystrophy. So this is a very simple thing, and particularly I thank Dr. Sindhu, who recently presented on CMD, and this was derived after the reading. So I think with this, I will like to wind up my talk, and thanks to everybody for listening, and thanks opportunity for given to me to speak on this disorder by ORD. Thank Dr. Sudhindra, Mr. Prasanna, and your entire team who give so much of importance for these such groups of disorders, which are rare, and I would say they're ultra rare, but they are not rare given the population, like particularly in India. None of these diseases are rare because given the sheer numbers, they are very common. But compared to several other common disorders, these are rare. But they also need to be taken care of because we have young couples, and particularly with consanguineous marriages, these diseases are a big burden to the families and also to the society. Thank you very much.
Thank you very much, Professor Nalini, for giving an excellent talk and a comprehensive overview of congenital muscular dystrophies. We have few questions. I think the first question we'll take from Professor Ganda. Ma'am, do you want to ask the question or should I take it up?
I'll say escape.
You can take it up.
Ma'am, the first question is, have you seen any non-penetrant cases of Bethlehem myopathy? Is CPK raised in megacolon myopathy? And CKBP, is the CKBP gene related? And how do you confirm FSHD genetically? So 4 questions. The first question is, have you seen any non-penetrant cases of Bethlehem myopathy? Everything is autosomal recessive, or how sort of genetics you are seeing?
No, we have seen majority of the Bethlehem myopathy were autosomal dominant. As I showed the father, the daughter, but we had 2 brothers who were affected and born out of consanguineous parents, the one with extensive keloids. So, but the majority were autosomal dominant, but few of them were autosomal recessive. So both varieties we have seen, and obviously we just do clinical exam and we've been able to confirm the diagnosis.
Ma'am, the second question there it is CPK raised in megaconal myopathy? Have you seen anything like that?
Yes, yes. It was not very grossly elevated, but maybe about 3 or 4 times elevated. It was around 600 to 800. It's not like the dystrophic pattern where it is very high in thousands, nor is it like myopathic pattern where it is normal less than 100 or within 200, but it was elevated. And lactate was also elevated.
And ma'am, was there any association of CKBP gene to megaconal myopathy?
No. The CHKB gene causes the congenital muscular dystrophy, particularly with the in the muscle biopsy. There are giant mitochondria which are identified. So it is a form of mitochondrial gene disorder only, which the choline kinase gene is affected here. But maybe I may have to read little more on it. But this is so ultra rare disease that we have just 3 cases confirmed.
Ma'am, one more question that is coming up here is a 2-site ELISA is used for quantification of dystrophin. Can you elaborate on that? Have you used a 2-site ELISA for dystrophin quantification? Because you have consistently stressed that muscular muscle biopsy is probably not the first way to go because you are getting most of the cases by genetic diagnosis and a clinical, very well clinical phenotyping. Is there any role for ELISA-based dystrophin classification?
Actually, honestly, to tell you, I'm not aware of this particular test for dystrophinopathies or quantification of dystrophin protein. So what we were doing, I mean, you would also very well know that maybe more than 15 years ago, the muscle biopsy, and we did immunohistochemistry for expression of the dystrophin protein and the staining. So either it is completely absent, we'll call it as Duchenne muscular dystrophy. If it is partially absent, we'll call it as Becker muscular dystrophy. But you see, today with just MLPA, multiplex ligation probe amplification testing, we can get more than almost, if your phenotyping is correct, like our experience. So when we say Duchenne muscular dystrophy, almost 80% of them are confirmed with just MLPA testing. Either it could be deletions, which is very common, then duplications, and yes, for point mutations, the remaining 20% we have got invariably a positive result, except for 3 to 5%, even with next generation sequencing that we could not identify. And those obviously we have done muscle biopsy. We also tried doing mRNA studies, transcriptome analysis. Only 2 cases we tried, but we could not identify any mutation in that. So it's such a small number, hardly 3% of suspected dystrophinopathies that you cannot identify by a simple blood genetic test. And so I'm not sure this ELISA test is with blood sample, is it?
Muscle samples, ma'am. 2 site samples.
So I'm really not aware of this.
Ma'am, one of the reasons why these kind of things are coming up is they are multiple drugs, orphan drug are being tested for various neuromuscular disorders, and quite a bit of drug repurposing trials are also happening. So they are looking for surrogate endpoints, and during that surrogate endpoints, instead of going for clinically relevant surrogate endpoints, they are looking for molecular markers or histological markers, and they are taking multiple site punch biopsy samples to test whether the treatment has caused any change in the dystrophin level. How do you agree to these kind of surrogate molecular end markers, or there should be improvement for any type of rare disease drug? This is a general question.
See, currently, if I have to tell you, Sudhindra, we have undertaken the Atchayaram drug trial in Duchenne muscular dystrophy, which is an oral medication. And the outcome measures are totally different. Like, you have the 6-minute walk test, then you have the upper limb functional test, the North Star ambulatory test. So we have various parameters we can assess, and we are doing it it is for the next 3 years that we have undertaken this Atchayaram drug trial. So the markers of improvement could be more like functional assays. Yes, well, I mean, several years ago when they did the myoblast transplant into the muscle of the dystrophin, grown myoblast, and they did serial biopsies like every 15 days or every 3 months, I don't recollect, but that really did not give a overall picture. Like you may just take a muscle biopsy from quadriceps or biceps and repeatedly do this invasive procedures and just to see quantifying dystrophin in the muscle after treatment. But I don't think whether that quantification can be 100% correct, because different muscles express dystrophin differently, and the muscle that we are going to biopsy may not be a surrogate marker for the entire process that is going on. But currently, with this sort of even gene therapies like etaplersen, whatever is undergoing for Duchenne muscular dystrophy, it is only serial assessment of several motor functions that are being undertaken.
And the next question is, have you seen any India-specific variants in congenital muscular dystrophy genes? Is there any founder effect? Did you find out any of them?
In the genetics?
Yeah.
Okay. So actually, that's currently what we're doing, but I don't think so. We have found any founder effect. Even in the big group of the collagen 6 myopathy that we saw and the LAMA2, we did not find definitive founder mutation. A group of samples was tested by Dr. Nalini Atchayaram. I'm not sure if he's on the line. He can answer if he found anything specific in the small group of patients that they tested. But to our knowledge, currently Dr. Gautam has been doing the analysis. I don't think we had any founder effect in any particular gene.
And the next, it's not a question, it's question plus compliment. Professor Kaushika from Mumbai. She says that it's an excellent seminar series. I wish more basic biologists come to this. A lot of ways to think of new means to work together. So as a general question, how should basic researchers in India approach clinical, especially neuromuscular disorder specialists like you, how to take these kind of talks and work on various diseases, especially in context of India, where we would have far more diversity in the genetic diseases.
That's nice, Sudhindra. You see, we clinicians are drowned with clinical work, and we have hundreds of patients. Particularly in setups like NIMHANS, AIMS, JIPMER, PJ. But then we would love to work with basic scientists, and you know very well that at least at NIMHANS and certain central institutes, we collaborate with basic scientists. I work with CCMB. I have worked with NCBS. Now, currently, like GNE myopathy, we are doing iPSC stem cell work with monocytes derived from the blood samples of GNE myopathy. And yes, Duchenne also, like when we did the mRNA studies, we did next generation sequencing. I mean, we'd love to collaborate with geneticists. We are already doing that, but with basic scientists, like as even in NIH, even people are still working on the development of normal muscle itself. And what is the difference between the development of normal muscle and abnormal muscles, like particularly with the dystroglycan group of disorders, which affects the brain, eyes, and muscle? So I know that there are hundreds of basic scientists in India, but we should have a platform where we can get together. And now it is presently like I have a friend who's working on this disease. I have another friend who's working on the disease. Can you give us some samples? Can you share your blood samples? So it's at that level we are working. But maybe basic scientists should have contact with clinicians, and we will be more than happy to give samples. In fact, recently we have transported some samples. I know that I shouldn't be telling this, outside the country in dry ice. I'm not, but I'm sure that we have scientists to do that within India. But it's only that lack of awareness, and we are not aware as to how many basic scientists are working with clinical samples.
Yeah, ma'am. So there needs to be a easy platform. There is a requirement for an easy platform to basic researcher and clinician interaction.
Yes, exactly.
And a couple of clinical questions are there, ma'am. We will send it to you via email.
Okay.
But because they are becoming, they are a little more concentrating on the clinical part of it, I will send it to you via email.
Okay.
And we have hit the time, 5 o'clock, and it has been an excellent talk, ma'am. And thanks a lot from the Organization for Rare Diseases India side and our sponsor Lifestyle side for providing us this comprehensive webinar talk on care for rare. Thanks a lot for everyone to join.
Thank you so much. Thanks everybody. Thanks Sudhindra and team.
Thank you, ma'am.
Thank you so much, madam.
Yeah. Thank you. Thank you, Mr. Shuru. You're the pillar of all this work. I know that very well. And thank you so much for taking these things forward. And I think you're the brain behind all this. I appreciate your efforts, Mr. Shiron. Wonderful.